back to our case, this is a patient that presented with locally advanced disease, high-grade disease, and was early on put on androgen deprivation therapy and showed an initial response, but quickly, within a year, developed castration-resistant disease with a rapidly rising PSA. There's 2 points that are really critical about that. One, we mentioned earlier that the short course and maybe incomplete PSA response to primary hormonal therapy really predicts for a bad outcome associated with these patients. But secondly, it suggests that maybe that androgen deprivation up front was incomplete. Drugs like enzalutamide, abiraterone, apalutamide, they offer the opportunity to be more complete in our androgen blockade. So not only blocking testicular testosterone, but testosterone activity produced either by the tumor or the tumor microenvironment, and also blocking it either at the production level or at the receptor level. Those mechanisms have been now validated as improving survival and disease progression in patients with castration-resistant disease. And I think they're a really important cornerstone to how we manage these patients. It's just that we know that they're incomplete too, in that these patients are going to go on to secondary resistance, more complete androgen receptor, refractory disease. And it's in that setting that we need to start thinking about additional therapy. So back to our case, that's the setting the patient developed osseous metastatic disease, symptomatic disease, ALK-Phos elevations, and other signs of complications related to that bone metastasis. That's why in this case, this patient was treated with radium-223 because it's shown a survival benefit in that exact setting. And it's also specifically targeting that bone microenvironment. And one of the real biomarkers associated with that is a decline in alkaline phosphatase. And we see that in this case where the patient's ALK-Phos drops from 268 down to 80. That in general is associated with a good treatment outcome, a longer survival in these cases. When I'm treating a patient with drugs like enzalutamide or abiraterone, we commonly see an initial response by PSA, but we can also see side effects associated with these drugs. And sometimes it's difficult to tease out what's a side effect from the drug and what's really related to disease. So to me, PSA becomes sort of a marker for reevaluating that symptom profile. And what I mean by that is if the patient's PSA is rapidly dropping, maybe other markers like ALK-Phos are responding, there's indications of disease response, maybe objective disease is regressing on CT scan. That gives me confidence that the drug is working. This is probably not a disease progression profile. And those symptoms that the patients may be experiencing could be directly or indirectly related to that treatment, enzalutamide or abiraterone or what have you. But as that patient goes on in course, as that PSA naters and begins to rise, particularly as the PSA rises, that's my cue to start looking for symptoms and reevaluating, are any of these things getting worse? Patient may not necessarily report this, but I'll ask, are you moving around less? Are you doing less activity? Are you sleeping less? Are you having more pain? Are you changing any of the medicines you use for pain? Are you having any issues with appetite or with energy? These are the kinds of symptoms that I think can be subtle, and they're not going to be cumulative from the enzalutamide or abiraterone. They're generally going to be stable from that, but in the setting of a rising PSA, that's where we see them. Both in the PREVAIL study as well as in the Cougar 302 study, when patients, their median time to PSA progression was around 11 or 12 months, their median time to patient-reported outcome, the FACT-P score dropping, was just about the same time, 11 or 12 months. And even physician-reported performance status changes. Median time to performance status decline in the Cougar 302 study was, again, 11 months. So all of these things tend to happen around the same time period. And to me, it's really a cue to say, okay, are these symptoms, do I think these symptoms are real? Do I think these symptoms are related to disease? It may not be radiographic progression. That may come 6 to 8 months later, but that's an indication to me that that bone metastatic disease is driving a symptom change. And I'm going to use drugs like radium-223 to treat that sooner rather than later.